Welcome to our series of healthcare scene interviews where we sit down with top leaders in healthcare IT. We're excited to be doing this live on Blab. We're also going to be posting it recorded on YouTube and distributed as a podcast on iTunes and your favorite podcasting platform. Today, we're excited to have Melissa McCool join us as part of a new set of interviews we're calling our Founder Stories. How a company was founded tells a lot about the company. So we're excited to learn more about Melissa and her company, STI Innovations. Melissa created STI in 2009 when she was a nephrology social worker. While working with her depressed dialysis patients who would not seek outpatient psychiatric care, she attempted cognitive behavioral therapy, or CBT as it's known, but found there wasn't enough time in the busy medical setting for formal CBT. She modified techniques and principles from CBT, mindfulness, and solution-focused therapy to create STI. Since then, STI has really evolved and been creatively adapted for a number of clinical settings and medical disorders to assist the most vulnerable, disengaged patients. And I know that's a theme that many of us in healthcare really love to hear about. So I'm excited to have Melissa McCool with us today. Welcome, Melissa.
Thank you so much. It's an honor to be here.
Great. So let's kick it off. I mean, I briefly covered some of your history, but tell us, what really motivated you to create STI Solutions and, when you first started the company?
Well, I didn't start out to create a company. What happened was I was working as a nephrology social worker, and my background is in medical social work and also in mental health. So I'd worked in outpatient psychiatry. And when I started working in nephrology, I developed relationships with my patients, and a lot of them, probably 25% of them, were quite depressed. And at that time, we were supposed to refer them to outpatient psychiatry, but they wouldn't go. And it was hard because I really cared about them. And honestly, it was difficult for me to tolerate working with them because I know what that feels like to have a lot of despair. I have a son, I have 3 kids, and my middle son is on the autism spectrum. And when we realized that he, something was wrong with him, or he, had autism, I basically kind of plunged into a really bad depression, but continued to sort of function and didn't ever get help for it. So I know what that feels like when you're really in a dark place. And so ever since then, it's really hard for me to be with patients when they're there because I know what that feels like. And so I started on the weekends just basically trying to figure out what we could do because there were a lot of articles on the problem, but not a lot on the solutions. And so I taught myself CBT and took a few courses, read some books, and I tried to do formal CBT, but I found that it really wasn't conducive because you don't have a lot of time. And so I found myself saying, well, here are all your problems and your different issues. You can't sleep, you're worried, you feel bad. Why don't we just focus on one of them? And I found that by doing that, the patient wasn't as overwhelmed by their problem and I wasn't as overwhelmed. So it enabled me to kind of move forward and focus and the patient. And so what I would do then is, if, let's say, they couldn't fall asleep at night, I would use some of these really cool techniques from CBT, and then I would kind of help them fall asleep. And then interestingly, once we kind of resolved one element of the problem, the entire trajectory changed. And there was a domino effect, and they basically started getting better. So that's what happened. And then I wrote it up based on the encouragement of one of my colleagues. I wrote it up, and then she said, let's do a training video. So we did a pilot. And after the pilot, because a lot of other social workers, we had like 46 in the study, they also had very good results. Then people were basically ambushing me. What are you doing? And so that started a website, and then it really kind of morphed into a business. So because it's easier to start a business than a not-for-profit. So really, I'm really an accidental kind of entrepreneur. It really wasn't by design.
I think that's true for a lot of entrepreneurs. Alex brought up an interesting question. He said you taught yourself CBT. I mean, could anyone do that? I mean, you have a background in this already, right?
Yeah, I mean, I had training in psychodynamic psychotherapy from my work in New York. I have a master's degree in social work, and so I had done some of that work. I just hadn't studied CBT. I took a very small course in it and basically bought a bunch of books on it. And and again, I didn't have formal CBT training. I did with this one little course, but it wasn't like a long-term, year-long training. Really, my philosophy then, and it continues to be, is that something's better than nothing. So the patients weren't getting anything, and I wanted to try and do something, and it just sort of creatively has evolved.
Interesting. Well, it sounds like, you went to the extra effort of trying to understand how you could help your patients, but then you realize that's not really scalable for everyone. Is that a fair to say? That's kind of the genesis of SDI, is how do you make that more accessible to everyone? Is that essentially what you've created?
So, yeah, you mean, wait, what's not scalable?
Well, everyone being able to train in these techniques and understand how to make them easily implemented. And, I guess you also commented that you didn't have the time to do full.
Yeah, exactly. So what I did is I basically kind of jerry-rigged a system together that would work. Meaning if you have 15 or 20 minutes and you're a clinician, you can use this to really help your patient, because they're very concrete kind of tools that people can use, and really anybody can use. They're essentially coping tools. And that, by the way, was back in 2000 and, well, I started doing it 2009, 2010. The first study was published in 2011. So essentially I've devoted my life to it since that time. So it's evolved a lot, meaning now we know how to talk to patients in a way that they can hear it. And that's where some of the solution-focused therapy and a little bit of motivational interviewing comes in. And also to teach clinicians so that they can understand it, because not all clinicians have a background in mental health. So the question becomes, to your point, how do you scale it in a way so that all clinicians can use it? Social workers, and I'm doing some things so that even non-social workers can use some of these techniques to really help their patients cope better with life, basically.
That's great. So, let's talk about some of the impact that these techniques have had. And what are some of the stories of social workers that are using it, or other people? How's it changed the way they work?
It's interesting. It's changed in a couple different ways. Essentially, there are two very large corporations who are using STI. One is called Fresenius and one is called DaVita, and they both have. It's probably 4,200 clinics around the U.S. So essentially all of their social work staff are using STI to help their patients, and really to help dialysis patients who are struggling with mistreatments, who are at risk for hospitalizations. And so it helps decrease hospitalizations. It helps with depression scores. It helps with mistreatments. So it really essentially seems to help across all the different clinical outcomes. But what's interesting about it, and I think this is worth pointing out, it helps all the medical outcomes, because essentially the patients are starting to function better in their life. And I say that because what we're doing now is we're not necessarily focusing on the medical problem per se, because as STI has evolved and as different medical companies have started using it, they've really wanted to use it for the people who struggle to come to treatments, who are at risk for hospitalizations, the disengaged patients. We discovered something very early on, and that is people don't want to talk about that, meaning they don't want a clinician to say to them, hey, you're not taking your medications, because that's we say that over and over, and why aren't you taking it? That's actually not how you engage them. What that does is really it triggers their shame and it triggers their fear. So the irony is that the medical system's insistence on talking about medical problems inadvertently pushes people away. So we found that's actually not how you engage them.
So what's the
the alternative is you basically talk to them about anything other than that. I mean, if they want to talk about their, taking their meds or missing their treatments, then we'll talk about it. But essentially it is patient driven. So they're talking about the content they want to talk about. And what we're doing is we're weaving in these coping tools based on how we see they're coping, how they're coping or not, and essentially give them little things that they can use on a day-to-day basis. So we engage with them in their life, because the truth is when people aren't doing well with, in managing their medical conditions, they're usually not doing better or not doing well in other areas of their life as well. Their medical condition is just one element of their life. So
interesting. And when we talked before this chat, I found it really interesting that you were really focused, or at least in your experience, you realized that many of the people who needed this are that 5% that cost 50% of the healthcare, that we've all heard that stat, right? And that when you deal with those people, it takes a little extra effort, or, talk about that and your experience with that 5%.
Yeah, so essentially, again, although I developed STI to work with my depressed patients, again, we found that it helps people, again, take their medications, come to their treatments, and basically do what is in their best interest to do. But what's very curious about it is that a lot of the patients are more challenging. And if there are any clinicians listening on the phone, they certainly understand what I'm saying. Meaning, there are some people, when they come to their treatments, they'll say, oh yeah, no, I'm absolutely taking my medications and I love it and it's fantastic here. And then you look and you're like, but wait, they didn't show up. And you look at their labs, like if they're diabetics, you can see their A1C. There's no way they're doing their insulin. And so it's confusing, because you end up getting into almost a power struggle. Like, wait, no, you can't possibly be doing this. Yes, I am. No, you're not. Yes, I am. I love it here. It's great. And then I realized, what's interesting is you can't approach those patients in the same way. So essentially, the idea that you would approach all patients in exactly the same way is also very mistaken. Meaning, we approach those patients in a very different way, and I've developed some creative roundabouts that allow those patients to engage, because they engage differently. But what you were alluding to, that you and I spoke with earlier, is that the clinicians themselves, there's a dynamic that involves the clinician and the patient. So if you're talking to a patient and they don't seem interested in what you're saying, the clinician starts to disengage from the process. And the clinician starts telling themselves, oh, it's because I don't know how to do it the right way. And, oh, you know what, they're not that interested. I'm going to go to someone else. It's not going to work with this person. Or we also found that clinicians, we would give them a list and say, okay, here are 10 patients in your clinic who are missing treatments, who are at risk for being hospitalized and really at risk for dying, because we know that when patients miss or shorten treatments, dialysis treatments, that they're at risk for death and mortality. So we would say, go work with these 10 patients, and actually only 30% of the clinicians would. They would say, well, it's not going to work with that one, so I'm going to go with this person. I'm not going to do that. And that is really fascinating. And I've really never seen any articles on that it's the clinicians also have their own reactions to it. So what we started doing is essentially training STI, not just to the patients, but training it to the clinicians, that they use it on themselves first and then go teach the patients. So that, because if not, there's a real parallel process that happens with the clinicians and the patients.
It's almost like they're applying their preconceived judgments, and you're helping them to avoid them. Is that right?
Judgments, exactly. Work on their preconceived judgments, because the truth is that what we found is that those patients absolutely do engage and they get better, and it's very dramatic, and you get choked up. Like when I hear cases, it will make you cry, because these are patients where no one's ever consistently worked with them and tried week in, week out, and tried in a consistent way to help them. And you know that if the medical staff is having a hard time engaging with them, that the truth is they're probably struggling in other areas of their lives too. So there's been a real ripple effect with these patients. So.
Interesting. So what are all the different areas that your techniques have been used? I know you started with social workers. What are the different specialties or types of patients that it's been used with?
Well, primarily it's dialysis, nephrology, social workers who are using it. Mm-hmm. However, a Kaiser Permanente, they're using it in their collaborative care study, which involves their primary care clinics. And I recently developed a program for chronic care management. Anybody who has, 2 or more chronic conditions. So that's a program that I'm piloting actually with a hospital group in Ohio using medical assistance. And that's not STI per se, but it's more of a derivative of STI, using some of the same things in a slightly different way to help chronic care management patients.
So, and will that piggyback the chronic care management code as well, that they can get reimbursed for the services?
The CPT 99490. Yeah, so I'm trying to kind of figure out how to help those patients.
Interesting. So tell us about the process. How do you train a medical professional in your techniques and solutions? What approaches do you take?
Well, it's interesting you ask that, because what has happened again, so for the past 5 years or so, has involved me really writing and studying how people use it, what works, what doesn't work. So early on, what I was doing is I would write, I just would write things up, like, here's kind of how you do it, and I would show a video. And what I found is that people like it in theory, but they wouldn't use it in practice. So then what we started doing is doing that, plus we would have them practice it on each other. And that seemed to help a little bit. Then we started having them practice it, using themselves as their own patient, and then using it on a couple other people. So really kind of playing with it in different ways to figure out how do they learn best. So initially the video was like a 2-hour-long video. Well, most people don't watch 2 hours because they space out. So now I teach it in like little tiny clips and vignettes. So everything, it's more because I've had to really learn learning theory to figure out how people learn and how they apply it, because a lot of stuff, you don't want people to just learn it theoretically and not go practice it. And so that actually has really been a lot of what I've tried to do, is how do you teach it in a way so that the clinicians can engage. So there's also, you're teaching them intellectually, but you're also teaching them emotionally, because people have, again, preconceived ideas. I'm not a clinician. I can't do this kind of work. So we're trying to teach them cognitively, but also give them really the belief that they can do it. So there's an emotional kind of support and helping them work with their thoughts there. So that it actually works on a couple different levels. And the environment, and this kind of loops back to something you mentioned earlier. So one of these big companies, well, both of them, but one in particular, they basically shifted the entire work life of their social workers. So instead of their social workers essentially making phone calls to insurance companies and calling transportation, the social workers are spending a good chunk of their day doing STI and doing other counseling type things to do real active disease management. So they're using their staff differently. So,
and so tell us about MindStile platform.
Yes, I'm sorry, and I forgot. I didn't even get to that. So there were some Canadian social workers who found out about STI, and I was sending them this stuff, and it's like 300 pages, and now we have like almost 100 little video clips, and there's all this content, and I realized it doesn't make sense to scale it, and then there's a group in Scotland who are using it. So I decided over the summer, and actually I spent with the team about 4 months taking all the content and putting it on this digital platform and arranging it in a way so that it's more of a multimedia kind of learning experience. So that's what we call Mind Stile now. So essentially it's a digital platform, online training platform. And we have it now where social workers, I'm trying to figure this out, because again, remember, I'm not really a business person. It's sort of, it's accidental. So I'm trying to figure out which way works best. Right now we have a subscription model at this point, and we have quite a few social workers who are on learning that way. But then these other kind of different programs that I'm doing, those are probably going to be licensing agreements. I'm still trying to figure that out. You have to, that's the interesting thing about starting a business. You have to try things, and then you have to fail, and you realize, oh, that didn't work out. I wonder if I'll try this. And
interesting.
The highs are highs and the lows are low.
Indeed. As an entrepreneur myself, I know all about that. You may have to use some of your techniques on yourself as maybe
Yeah, no, I
entrepreneurs is the
do.
next category.
Absolutely. Yeah, I
No, but
do.
it's interesting to see it evolve, and it's interesting to see you dealing with mental health treatment because, I mean, if you look across healthcare, I don't think mental health has received the attention it deserves. Why do you think that's the case? And do you think STI is making it simpler so that becomes more of the case for more people? Or, what's your thoughts on?
Well, yeah, because it's funny because we talked about this a couple days ago. So honestly, if you look at the statistics, it's really shocking the number of people who don't get any help, who suffer silently. So I think with depression, it's like 15% of people ever get any kind of help at all, like essentially none. And I think they're even including people who just get meds from their doctor, which in my opinion is not really treatment. I mean, it's helpful if you need an SSRI, although that's a whole other discussion. But I think they don't because there are a lot of barriers set up. I mean, a lot of barriers, meaning you have to, number one, you have to call, you have to figure out, depending on your insurance, usually the insurance company puts the onus on the patient to make a bunch of calls to find somebody. Then you have to find a therapist, you have to schedule a time, usually you have to wait. If you're at Kaiser, like an HMO, they've been sued because it'll take 4 to 6 weeks to get a simple appointment. And so the problem is that when someone's in a bad place, especially with depression, but also with anxiety, and by the way, those are just your sort of vanilla, and they're mental health issues, but they're actually issues with life because quite frankly, I don't know any person who hasn't gone through a period of anxiety or depression. So in some ways, I have this personal aversion to mental health. I mean, it is mental health, but I think it's called being a person.
Yeah,
because life is really hard. Yeah, I mean, life is hard. So the fact that people have to go through so many hoops to get any sort of help is really amazing. And not only that, so by the time, if you're a therapist, and by the way, I was a full-time therapist for 4 years. So by the time someone comes to you, if you're a therapist, you have a very active, engaged, motivated person. But the truth is, it takes a lot of ego strength and it takes a lot of inner reserves just to even get there. So the people I worry about are all those people who they're not organized enough. They have too much chaos in their life to make a phone call. They don't have enough resources to make the $15 copay. Like those people, they don't ever get help. And I feel horrible for them. And so actually, STI just helps them with the health part. I think that we have to figure out other ways to help people in a way that they can hear, that they don't have to admit, I have a problem and I need help, that we can identify, we know that there's a problem, we can actually get to the solution without admitting a problem and actually give them some of these tools, which are not hard, they're very simple. Give them to them in a way, in a place that they can hear them for free. Or for like a tiny little bit of money. I mean, really.
Sure.
And I know that's a big task, by the way. I know that's, so.
Yeah, but, that's what entrepreneurs do. They tackle hard tasks. And obviously, I mean, if you look at the best innovations in entrepreneurship, they're all things that you look back and say, oh, yeah, that makes sense. Why didn't I think of that, right?
No, it's right. And it's interesting. People have talked about the Uber of the healthcare. And I think the Uber of healthcare will involve something like that, where it's essentially helping people, not requiring them to jump through all these hoops and barriers to get simple help and tools and coping tools. Because again, I mean, even if you look at the DSM for billing purposes likes to put people in little boxes and in little categories. But you know what the truth is? And again, I see this with utter confidence as someone who has had to diagnose people and saw thousands of patients, because at Kaiser, that's what you do. The truth is, people don't really fit into neat little boxes. And a lot of times they'll look this way, but actually, well, they have a little bit of this. It's not really so neat. So I think that giving people tools that they need is actually a much better way. And messaging them in a way that they can accept them, not saying, I know you have a problem, you need to admit you have a problem, but essentially saying, however it is, and again, there are lots of little roundabouts that I could tell you about, ways that people start accepting help that doesn't require them to say something's wrong with them, because nobody wants to think something's wrong with me. You want to feel like you're doing well, and here's a tool and you can use it, and then look, I can accept it. So that's what I'm interested in.
Yeah, and in the chat, he commented that's all of healthcare. We try to box it in, but it's such a
it's so complicated. It is, and no one likes that because it's messy. Quite frankly, all of this is very, very messy. And someone, I see a question, peer review studies. There have not been any peer review studies, mostly because it's so new. And interestingly, now you guys probably aren't going to like this. Or I don't know if you're not going to like this, but the truth is the kind of patients that I'm committed to helping, which is the 5%, they actually won't sign IRB papers to do consent. So these patients, it's very hard to get research on them. Because again, if you're doing an IRB study, we're doing an IRB study on transplant using STI post-transplant. I didn't mention that, but how to help them. And it's more of a curriculum-based program that I developed. But they actually, the amount of forms that they have to fill out to go through IRB, they have to sign a lot of stuff. If anybody who's worked in healthcare, the 5% are not going to sign any forms. Sometimes they won't even talk to you. They aren't going to sign your form to be part of your research project. So now listen, this is where I found this out, because when we did the first pilot, so the pilot we did was essentially it was a QI project. So it didn't require IRB. We sort of kind of went around so we could figure out how to do it, to look at it. And we got very good results, by the way. But what we did is we trained the social workers on STI and said, hey, go pick two or three of your own patients. So they picked 2 or 3 of their own patients, and they picked the cooperative, kind of nice patients. So we got really great results, right? And everyone gets really great results. All of research, you know what, I hate to say this sounds bad. I don't want to say it's rigged, but people know what they're looking for. So we got great results. So then when you take those results and you take that approach and you go try to use it with the 5%, it doesn't really work. So I spent like a year modifying things, trying to figure out, okay, well, we know this works with cooperative kind of engaged patients, but what are we going to do? Like, what do we need to add? How are we going to work with the patients who at first glance are not engaged? They are engaged, but they engage in a different way. And what can we do to help those patients? So actually the models looked very different. I had to add a lot more stuff, and I had to really creatively figure it out. It's not the same. And that's where research, and I'm not an academic, by the way. So to get all the research dollars, you have to be affiliated with the university, and I'm not. So, and that's not, what I'm interested in doing is coming up with solutions. You need research to essentially add validity and credibility. But again, the 5% aren't going to sign up. So how are you going to get the research? I don't know. Or peer-reviewed articles or a double-blind study. You know, I don't know. If there are any academics, they could help figure it out.
Yeah, and I mean, I've heard it over and over across all of healthcare is how do we accelerate the pace of, those findings so that you can actually, get the stuff implemented. What is it? I think I read something yesterday, 16 years to go from concept to actual implementation with peer-reviewed research studies and then, then push it across all of healthcare. It's just too long.
It's long. And by the way, I don't mean to, I think Alex asked, there are some studies that have been done. And when I mean peer-reviewed, meaning going through IRB and, actually the corporations who are using it have done a lot of research on it. But again, depending on your background in research, you may or may not like their studies. There's a Wikipedia. You can look up symptom-targeted intervention on Wikipedia, and you can see all of the research articles that have been done on it.
Nice. So let's finish this off with maybe your favorite story. And the story of a patient, obviously we want to be, cognizant of HIPAA. You don't have to mention who the patient was or anything, but, what was, is there an example of where you've used this and it's changed a patient's life? I mean, tell us the story behind STI.
Okay. I got a great story. okay, here's a great story. Actually, two came to mind, but I'll tell you the one where it was my patient. So I had a patient who, and I'm changing some of the information to protect it, but
Sure,
I had a patient who was in her 30s. She was actually a double amputee, bad diabetes, on dialysis, and living in a nursing home. And she would come into the dialysis unit, and she was so profoundly depressed. And so she wasn't much younger than I was at that time. And I would go in, and she was so in such a bad way, it was almost hard to talk to her. Like, I wanted to help her, but what I found before I started doing STI is I would go over and I would sit with her, and I would start feeling really depressed too. And emotions are contagious, so that makes sense. And I would talk to her, and I would talk to her, and I would try to, just give her support and really encouragement, and nothing really was working. And so when I started doing this with some of my other patients, I thought, you know what, I'm going to go try it with this patient. So I went over, I tried it. I spent about maybe 15 minutes with her, and essentially, oh, I'm so sorry. Oh, look at that. Technology, right? Your phone.
That's the best.
Oh my gosh, I'm so sorry, guys. I don't know how that, sorry about that. So I went over and I used some of the interventions, and essentially it's patient driven. So we're not kind of solving their problem. We're showing them some things, saying, and I showed her this little triangle thing, and I said, what could you do? And essentially what she was going to do is, all she was going to do is the next day when the nurse came in to get her out of bed, she was going to basically get out of bed. So we did a couple different things and a few different interventions. So she comes back a week later, and she is not in her gown, because she used to just come in her gown. She's actually dressed. She has makeup on. And she says, yeah, and I'm like, what happened? And actually the staff, we were all really confused, like, what in the world happened? Because it was so dramatic. And she basically came in and said, yeah, the nurse came, and I knew what I remembered what you told me, that I wouldn't want to, but I got up anyway. And she essentially went down, had breakfast, the nurse got her all dressed and ready. She got makeup on and got her hair done. She went down and she met all these people, and she found these buddies, and she became part of this this nursing home posse, which apparently there's this whole subculture at nursing homes that I didn't know about. And she came in a week later, and she was dramatically different. But a lot of it was the education, like sort of showing her things and helping her understand why what she was going through really wasn't her. It wasn't a personality thing, and sort of flipping it. So there was education, there were tools, and that was pretty dramatic. So that actually made me a real believer that just spending 15, 20 minutes, not all the time, by the way, but that sometimes you can get these amazing stories.
Mm-hmm.
So,
and it seems like a lot of people care. I mean, that seems to be missing in parts of healthcare, unfortunately.
What's missing?
Just showing that you care about the patient, and that they're a human individual. Actually, that, I think, to be honest, that might be why it works in some way, to some extent, more than we really fully appreciate. Because, no, I'm not kidding, because what STI does is it sort of helps people say, instead of tackling your entire problem, meaning you're homeless, you can't pay for your meds, you have all these medical conditions, you're this, you're that, and I'm so overwhelmed, I have no idea what to do. I'm just not going to do anything, or I'm going to pretend I have paperwork to do, which, by the way, it's not conscious, but I do think clinicians sometimes do that. I mean, I know I used to do that, meaning I don't know how I'm going to help this. It's so overwhelming. They're overwhelmed by their problems, and you're also overwhelmed by their problems as a clinician. Mm-hmm. So what I found is that instead of doing that, you can look at it and say, here's one little thing, and we're just going to focus on this one little thing. And the patient's like, yeah, I can do that. I can do that. And then that's what starts it, because that actually, it's just like a little tiny spark. It's a little anchor where you get in there, and that that grows. And so you're not overwhelmed. We don't have to do it all. We don't have to solve the entire problem, but we need to do something. And so actually the social workers have said that seems to be a consistent theme, that they're approaching problems in patients in ways that they used to avoid, and patients they used to avoid. So I think you're right, because even just the mere fact of going over and being open and available
to sort of help them or to even engage with them and work on this is huge. So I think if you're not a clinician, I think people overestimate what clinicians can do. And so giving the clinicians tools is very helpful.
Beautiful. What a great way to finish. Well, where can people find Melissa online and also the tool set?
Well, you can go to MindStile.com, and it's MindStile.com, and you can email me, and we can figure it out. I mean, I don't know who's on or who's watching, but anybody who's interested, I will talk to you, and we can figure out how to creatively implement it, because it does involve creatively coming up with solutions, because not every single disease state and setting works in the same way. So you have to sort of adapt it to some extent. So
excellent. And then also on Twitter, I'm sure they can see if they're following the blab at Melissa XX McCool, which is the coolest last name I've ever seen. So there you go.
Right? It's not even fake.
We're going to open it up to live questions to those watching the live blab, but I want to thank you, Melissa, for joining, for those that were watching the replay later and also listening on the podcast. Thanks for joining us. If you want to check out other podcasts that we do and other video interviews that we do, you can check them out at healthcarescene.com and find all of the different interviews, content, and information we do about healthcare. Thank you so much, Melissa.
Yeah, thank you.